Hi folks, today we're going to talk about noradrenaline or NORAD or norepinephrine if you're from North America. It's a commonly used drug on the ITU and in theatres, used in the control of systemic hypotension. We're going to look at the usual things, presentation, we'll look at mechanism of action, we'll look at the usage, we'll look at the effects, and we'll have a little look at pharmacokinetics as well of noradrenaline. So if we start with the presentation, it is an endogenous catecholamine, but this is obviously we get it in a synthetic form. It's a clear, colourless solution, and it comes in a variety of ampule sizes, but the most common one on the ITU is the 1 mg per ml ampule. It's often diluted into essentially an infusion, and you'll hear a lot of terms banded around, things like single strength, double strength, quad strength, and all that refers to is the proportion of noradrenaline which has been placed in the infusion bag. The standard infusion bag is a 50 ml bag of 5% dextrose, and then the proportion of NORAD within that is what gives you your single, quad or double strength. A standard strength infusion of noradrenaline contains 4 mils or 4 milligrams of noradrenaline and 46 mils of 5% dextrose. A double strength infusion obviously is double that, so that's 8 milligrams or 8 mils with 42 mils of 5% dextrose. And then a quad is 4 times 4, so you get that 16 and 34 of the dextrose. The rate is often altered depending on what you're trying to achieve. If you're looking for a specific mean arterial pressure, or you're looking for a specific systolic blood pressure, or in neurological patients on the ITU, sometimes the cerebral perfusion pressure. So moving on from that, if we have a think about the mechanisms of action of noradrenaline, noradrenaline itself is a potent adrenergic receptor agonist, and its predominant action is on the alpha-1 receptor, but there is a limited bit of beta adrenoreceptor action as well. Alpha-1, as we've said previously, is a GQ protein related property. It leads to an increase in phospholipase C, which leads to an increase in inositol triphosphate 3, leading to high levels of intracellular calcium, which leads to vasoconstriction and gives us that endpoint of the raised blood pressure / systemic vascular resistance. The beta endpoint on this is you get sometimes a little bit of positive inotropy and chronotropy, but it's very, very minor in the overall effects of the noradrenaline itself. So if we're moving on to the usages, as I mentioned earlier, is for systemic hypotension. Normally that is which is resistant to fluid challenge or fluid resuscitation. Typically these are the distributive shocks, so these are things like your septic shock, your neurogenic shock, and also in certain circumstances vasoplegia as well. Taking that on board and thinking about the effects of noradrenaline, as we've said, we've got cardiovascular effects, so we've got those alpha-1 effects. This leads to essentially initially a slight drop in BP, but then overall a raise in systemic vascular resistance, a raise in systolic blood pressure, and a raise in diastolic blood pressure. Consequently, you can get a minor drop in heart rate around that time, but generally that's overcome by the very weak positive inotropic and chronotropic effects of the beta adrenergic actions of noradrenaline as well. Coupled in with that, we should also be aware that you get some splanchnic constriction, which leads to a drop-off in renal blood flow and a drop-off in hepatic blood flow as well. One of the main endpoints that we need to consider when we're using NORAD, particularly at higher dosages on the ITU, is that you can get digital ischemia, and this can lead to gangrene, and this is commonly seen in the toes and the feet. And most people who've worked on an ITU will have seen some form of digital ischemia secondary to NORAD. It's one of the difficult challenges to overcome when using NORAD to try and keep people's blood pressure at an appropriate point. Moving on to the pharmacokinetics of NORAD. NORAD itself has two recycling mechanisms called uptake 1 and uptake 2. Uptake 1 is done by monoamine oxidase enzymes, and this is classically done in the end of the nerve terminal. And this is where the majority of noradrenaline is reuptake dependent and is reprocessed. And that's, as I said, is done by the MOA enzymes. The second is uptake 2. This is typically done in the distal circulation. It's a slight proportion of the NORAD overall, and it's actually relatively unimportant in our overall control of NORAD, and that's done by COMT enzymes themselves. The final thing to mention, noradrenaline is conjugated and is predominantly excreted within the urine. When considering the use of vasopressors as first-line treatment in shock management, it's important to have a little look at the SOAP2 trial that was in the New England Journal in 2010. It had a look at the comparison of noradrenaline versus dopamine. What it found was there was no significant difference at 28 days, 6-month or 12-month mortality depending on your first-line use of vasopressor. What it did find, though, was that dopamine was associated with a significantly higher episodes of arrhythmia and dysrhythmia when compared to that of noradrenaline, which is significantly important when you're considering what context you're using your vasopressor in.